Dean of the School of Basic Medical Sciences and Clinical Medicine at the University of Illinois at Urbana-Champaign. This morning I am pleased to talk with Dr. Arthur Goldman, a distinguished visiting professor of pharmacology and medicine, who has been with the School of Clinical Medicine for the past year. This morning we're going to talk about some of the historical experiences in the evolution of medicine that Dr. Goldman has participated in during the past half-century. Dr. Goldman received a Ph.D. in chemistry from Johns Hopkins University in 1923 and his M.D. degree from the same university in 1930. Dr. Goldman has lived through a very tumultuous age in medicine, and we're privileged to get his opinions and views at this time. I think to start this discussion off, Dr. Goldman, I'd like to begin by asking you the history of the measurement of cardiac output. You developed an acetylene method for measuring cardiac output very early. This has never, in a sense, caught on. Could you give us the history of this development?
Yes, certainly. The concept that one would understand the circulation only if one knew how much the heart was pumping, that this was an essential part of understanding the circulation. That had gone back from the time of Harvey, who discovered this circulation. But unfortunately, there was no easy way for measuring this. The closest was a guess as regards the output based on its size. Measurements were began quite early, but the methods used were so laborious the cardiac output. But in the human, this was considered to be too bold a procedure and too dangerous a procedure to be used, and hence only indirect methods were used. Most of the outstanding physiologists of the day, Haldane, Barcroft in England, in Scandinavia, a number of workers who came up perhaps with methods, some of which were, in the case of for example, the carbon dioxide method of Barcroft. In the case of the Scandinavian workers, the nitrous oxide method was quite good, but here again, this was laborious, and there were certain inherent errors. Well, the acetylene method, which we devised in 1926 or thereabouts, had many advantages. First place, this is a gas which isn't taken up by is soluble in water, and hence doesn't have the erratic solubility behavior that nitrous oxide has. It can be very easily analyzed. So this proved to be a very easily reproducible method, and by using it under various physiological conditions, it was soon shown that under basal conditions, the cardiac output was very fixed. One could predict it. 2.2 liters per square meter of body surface. Using the square meter is a better criterion, reflection of the metabolic activity.
Well, now you know with the introduction of the cardiac catheter and the introduction of dye dilution curves and the fifth principle that cardiac output measurements seem somewhat higher than this, and there was controversy.
Yes, well, the introduction of as I said, the introduction of direct puncture of the heart, which was done on animals, was really introduced in Germany at the time, a year during which I happened to be there on a fellowship, and was considered even by the Germans, who were rather, I must say, rather rough on their patients when it came to experimental procedures. It was first used there, and I received a letter from the group Baumann and Lauder. first two who did direct punctures on the human, and saying that their values were at least a little higher than the acetylene method which they had used before, and wondered why. Did I have an explanation? Well, I thought this was ideal because here, once and for all, one could prove by a direct method what the cardiac output was. So I rather expedited my trip to Germany, and we measured on one measurement a day on a patient carrying out. Now, the reason their values were high was the fact that, unthinkingly, Baumann and Lauder had always done an arterial puncture first, and although they were very adept at this, still this excited the patient having an artery punctured, and this is why their value was higher. Had they done the cardiac puncture first, and they would tell the patient that this was just removing a little blood from the chest, it wouldn't have mattered.
So did you do a acetylene method at the same time they were making the puncture method?
We did them on the same patients, comparing the acetylene method which we did first, and that didn't bother the patient, of course. And then we used direct puncture, but not direct, and the values were exactly the same.
How did you feel about direct cardiac puncture in those days?
Well, as I say, prior to that, I would have never given it a thought, although in using it on animals, it was innocuous, and absolutely definitely there was no trouble in doing it. It's was quite a safe procedure. It was more intuitive. After all, you're going through a thick muscle, and there was no reason for why one should get it.
Yeah, but of course, clinically, it hasn't proved entirely innocuous because it has led to pericardial tamponade and problems of that sort.
If you got a coronary, it would. And the surgery that we did, there was no trouble. That would be the one danger. But you might get a coronary artery as far as going through. And this, during that period, I happened to be over there, they were telling about, as they said, this crazy neurologist, as the Germans called him, who had taken a rubber tube, put Vaseline on it, and put it in his vein and shoved it down his heart to save during the puncture.
Right.
This was Dr. Richards at the time, was at Columbia, happened to be visiting Heidelberg. And there were many American tourists there, and my chief, Professor Meyerhoff, not being very cordial to him. He was a nice gentleman, but thought he was wasting a lot of time, so said, Roman, since you're an American, you take care of these visits. So I took Dr. Richards, and he came along, many others, and took him home for lunch and told him about this crazy urologist down below in this town that was doing this. Of course, that got him the Nobel Prize because he and Cournot then came to this country and used what I really mentioned as something that was of Hans, the thought of which was of Hans, and did their measurements.
Oh, well, you were working for Dr. Meyerhoff at the time.
I was also working at the hospital doing cardiac output with the acetylene method, which was being used. It was being used then rather widely.
Did you have any feeling at that time that you were involved in a great discovery, or at least observing a great discovery that would win the Nobel Prize for Richards?
No, I certainly didn't.
No.
I was afraid that if anything, anybody trying it in this country would have ended up with a malpractice suit, if not a prison.
Did you have any recollections of Dr. Richards and his approach at that time?
Oh, he listened to it very carefully. Fine gentleman. No, he didn't argue with me. So I'm rushing back to try this.
Well, the catheter achieved wide popularity in this country.
Oh, very wide.
But do you think it ever resolved the problem of basal cardiac output?
Never did, because you can never obtain a basal value in that manner. No matter how much you you have to do, to have him lie down and have his hands tied down and have a cannula put in on the tube. Although his metabolism doesn't go up, it's called an argument that I had with him regarding this basal and whether these are basal. No, what they don't realize is that any psychic effect, very mild, will raise the cardiac output of liters to 2 liters. I've shown that in early studies with the acetylene method on the students. We studied all the normal physiological effects of drinking water, of alcohol, tobacco, and amongst other things of psychic disturbance. And the way we did that was to have the patient basal, steady breathing, and then in connivance with the professor of the department, I had him come in and bawl out the student for having done so poorly, which they hadn't. This is touched the cardiac output again, and it was several liters higher. And that was the first study, I think, showing the effect of psychic disturbance, which I got if you needed any measurements. And this is what happens under those conditions. On the other side,
there are probably now thousands and thousands of papers discussing cardiac output in journals throughout the world, mostly measured with a catheter in place. And what you're really saying is that probably those papers are not measuring basal cardiac output, and some of the reference values are probably erroneous.
Well, very definitely, I think there's no question that they're erroneous and they're much too high. Now, I'm not trying to denigrate the catheter, because this is important for congenital heart disease, which we never measured with the acetylene method. If you've got an AV fistula, you'll still only measure what it would be without the fistula. But for that purpose, it's certainly, and for cardiac surgery, I think the fact that it was needed for that has led, as most other things, the doctor doesn't think of what the laboratory is going to get him. And since he set that up, it's easier to tell right in order to have a cardiac output feed, whether you need it or not, than it is to, say, have a procedure done. Recently, as you know, with new machinery that's available, mechanical advantages, rather than doing a laborious test, you couldn't do more than 12 readings a day. All you have to do is stand up, blow into the machine, and the miniature is printed out for you. So I think it'll have its now for, and particularly if care is taken, the basal values, that you still need the catheter to see what type of lesions, particularly the lesions amenable to surgery.
But non-invasive cardiac output will be measured.
I think it would be silly not to.
It will be with isotopic methods at the present time that you're referring to.
No, I'm referring to just a second. That is still the best test to use.
Yes. The problem is who is using the acetylene now?
Well, they're using it at the laboratory that I was associated with at the University of Texas. I don't know anyone else right at the moment who have adopted it or set it up. They've been using it under various physiological conditions.
You've also been involved in the area of hypertension for a number of years. You recently wrote a review of the current state of the art in hypertension. Could you give us some historical perspective on hypertension? What was it like when Dr. Goldblatt announced the Goldblatt kidney? What was the excitement in those days?
Well, the great excitement was, of course, the first notation of that the blood pressure might be elevated came from Bright. Bright noticed that pulse was hard, and he could tell the blood pressure was up. He could do it quite accurately. Incidentally, Dr. Fair, in presenting and doing grand rounds in the old-fashioned way, not giving a lecture, but bringing the patient down and and observing, and Sherlock Holmes method, would have you touch him. He would touch the radial artery and tell you what the blood pressure was, and expected the students to do it.
I wonder how many graduates of our medical schools today would understand the term Bright's disease.
Probably not.
Probably not as many as they used to.
Well, anyhow, he first noted that the blood pressure was increased. And he found that autopsy, of course, the patient has what is now known as Bright's disease, some form of chronic renal disturbance. And so it was obvious that the reason the blood pressure was up, it took a higher pressure to force the blood through the kidney to be purified, which made sense. But finally, it was some years later, it was noted that the blood pressure could be high without the individuals having the Bright's disease, having any disease of the kidney. And this gave rise to the two types of hypertension, those secondary to disease of the kidney, which affected its excretory function, and those not being accompanied by kidney disease. So this sort of, now Dr. Goldblatt's great discovery came from, although based on an erroneous concept, he felt that seeing patients, he was a pathologist with autopsy. One should always remember that autopsy is things have changed from what they were earlier. But at autopsy, there was also nephrosclerosis. The blood vessels, even in patients that didn't have Bright's disease, had nephrosclerosis. And therefore, it took more pressure. So he figured if that was the case, if you cut down the blood supply to the artery, renal artery, this would give you the same effect as an ischemia of the kidney brought about by nephrosclerosis. And he did this, and lo and behold, he got a beautiful picture and a good model, animal model in the dog of hypertensive disease without affecting the excretory function. And this was his great accomplishment. Unfortunately, interpretation, which doesn't matter, no discredit to him, was not clear. As long ago as 1895, two Scandinavians, Bergman, Siderstedt and von Bergman, this was a period when all you had to do if you wanted to make a name for yourself was grind up a tissue, inject it, blood pressure either went up or down because it's so sensitive, and you had a discovery. Of course, if you can get your adrenal medulla, you would discover epinephrine. With certain other, with the pineal, it came down. But that was of no importance. It was just ordinary tissue, so many of the discoveries. But in any case, the renal tissue, when they ground this up, why the blood pressure rose. And this was obviously the explanation, which is renin. And the renin idea, having something to do with hypertension, has not disappeared, as is still current.
Well, you know, Dr. Goldblatt made that discovery in 1923, about the time he was getting his PhD. And he worked the next 50 years to the end of his career, virtually right up to the time of his passing, on proving that that was the cause of essential hypertension, that renal ischemia was the cause of essential hypertension. He was clearly a very determined scientist. Do you have any personal dealings with Dr. Goldblatt?
Oh, yes, we were friendly enemies in a way. In other words, we disagreed mentally, but he was a fine gentleman. And remember the last time I saw him, just a year or so before he died. He was, as you say, from the time he was struck with this idea, and this is based, and quite logical, for the pathological viewpoint, but there were many reasons I needn't go into. It's well known now that you got hypertension if you remove the kidney. And the kidney, if it's a renin, or probably back from that, that if you took two rats and put them in parabiosis, took the kidneys out of one, they would continue to live. The one without without the kidneys, he should have had less running. His blood pressure went sky high. The one that has kidneys, his remained normal. That was experiments of that sort. The experiment of Doppler destroying the spinal cord in the animal. Blood pressure came down to below normal, but he still reacted to renin. These were simple experiments that showed that the renin hypothesis is no good. Smith's work and Castleman shown in biopsies of young individuals that long before they develop nephrosclerosis, they had their hypertension. I think that what you said, Dr. Goldblatt, I suppose, I think he was getting more convinced. At least he never argued about it later.
Well, I must say that I had the privilege of working with Dr. Goldblatt in his 80s at the Mount Sinai Hospital in Cleveland. And I wouldn't say he was real convinced that he was wrong. He was working right up to the very end to identify renin, to purify the protein.
He was hoping that an anti-renin substance would then be the cure. No, he hadn't found many today, despite it's all been done, still believe the same thing, Dr. Bloomfield.
Well,
I feel that I can see why he hadn't started this way, why he should have. I wouldn't hold that against him. I was reflecting on his ability.
It's been said that the Goldblatt kidney experiment initiated more scientific work than any other single experiment.
But certainly in hypertension, it started the field. It began, before then, it was an isolated experiment. Dr. Bell put a balloon around the kidney, and very isolated experiments. But no great interest. This really began again. Certainly did it in this year, after all kidneys are easily available in every rat. But the field has grown, and I think we know a lot about it now, thanks to the classic and work of Dr. Goldblatt. He deserves the credit for having initiated the field. And I'm afraid that some of the gurus, as I call them, who get a lot of the credit, and don't deserve it, that Dr. Goldblatt did not get.
Well, we still have a lot of essential hypertension around today, which is largely being controlled empirically through pharmacological therapy. But there still is no unanimity of opinion concerning the etiology of essential hypertension, is there?
No unanimity of opinion, no, sir, any more than there isn't say the unanimity of opinion that the earth is round. You'll find a few sects who still believe it's flat.
At the same time, you've watched a tremendous change in the drug therapy of hypertension. Can you comment on that, please?
Well, there's no question that once that with the growth of drugs, now that we can tailor drugs to do whatever we want, which couldn't be done before. We had to depend on naturally occurring empirical drugs. Now we can tailor a drug and once we know, say, that the alpha-nergic stimuli to the blood vessels cause constriction, we know if we paralyze those, we're going to get a relaxation, blood pressure is going to drop. We know if we've got centers in the brain, if we act on that control the blood pressure, if we act on them, paralyze them, the blood pressure is going to drop. And we can make drugs that will do these very things that we want. And that's the reason, really, the reason for the multiplication. There is no drug that won't either raise or few. It won't raise, lower, or very few that won't affect the blood pressure. But we can do it a little more accurately now. And so there are a number of drugs. But what hasn't been done, I think, and one of the greatest faults I find today is to think of hypertension and high blood pressure as a specific disease. It isn't. It's merely one parameter of the circulation and can be due to a number of causes. The most common cause of all is atherosclerosis. Because if your blood pressure didn't rise in atherosclerosis, you couldn't live. Your tissues wouldn't live. And that is confused by practically all scientific clinical records, and it's so simple and it's been pointed out so often, but still, and I think causes much confusion.
A very major contributor to the field of hypertension was Sir George Pickering. Have you had much contact with Dr.
Yes, I know George Pickering, Sir George Pickering, as he now is, very much. In the first place, I was on a symposium with him in Houston some years ago, and mentioned the salt restriction, which he participated in introducing with Dr. Tinsley Harrison years ago. And in mentioning that as a useful procedure in hypertension, Sir George, he wasn't Sir then, just George Pickering, professor at Oxford, said, that is like wearing a hair shirt. The morning papers, it was a time when nothing interesting and no murders were being taken place, ran headline, the Oxonian professor of Oxford says, leaving off salt is like wearing a hair shirt. Every patient, including congestive heart failure in Texas, dropped that salt thing and went back to eating assorted grams of salt. Page, the other guru, and he's now a philosopher, practically the physician's philosopher, this Corcoran had a little article in Time. They didn't write it, but it was reported in Time that salt restriction was absurd. A recent Tobian, there's a recent review in the New England Journal of Medicine saying that, salt, yes, now it's become important, but you don't have to restrict it very much. 70 milliequivalents is enough. Well, 70 milliequivalents is more than, and this was pointed out by Harrison and myself many years ago, was of no avail. So that the field is mighty badly confused, Dr. Goldman.
Even today, 50 years later. And Dr. Goldman, there are many other areas that we want to cover, but our time is running out at the present time. Thank you very much, Dr. Goldman.
My pleasure.